Hello everybody. Welcome to our YouTube channel No1doctor. Today we have interview with one of the best hepatobiliary surgeon. We will discuss the bile duct injury as one of the surgical problems. Welcome doctor.
Thanks for you and your channel subscriber.
Doctor. Common bile duct injuries represent a serious and challenging surgical complication. These complex injuries are most often a consequence of laparoscopic cholecystectomy. Proper management requires a skilled and experienced hepatobiliary surgical team. Doctor. What about the incidence of bile duct injury?
The number of cholecystectomies performed laparoscopically has increased steadily since the introduction of this technique in the early 1990s. Initially, the laparoscopic approach was associated with an almost tenfold increase in the incidence of bile duct injury as compared with open cholecystectomy. Subsequently, large surveys have shown that the incidence of bile duct injury as a consequence of lap cholecystectomy has decreased as surgeons have gained more experience with laparoscopic surgery. However, the incidence of iatrogenic biliary injury remains higher than in the open cholecystectomy era.
Doctor. What about the mechanism of injury?
Complete transection of the common bile duct is the most frequent biliary injury, and the most challenging to manage. This classic injury occurs when the common bile duct is mistaken for the cystic duct, resulting in clipping and division of the common duct, which is then resected with the gallbladder. The injury is often compounded by excision of a segment of common duct and division of the common hepatic duct. Despite this sequence of events, biliary injury is recognized at the time of lap cholecystectomy in a minority of cases. Contributing factors to bile duct injury include inflammation in the triangle of Callet, a short cystic duct, excessive cephalad retraction on the gallbladder fundus, and insufficient or excessive lateral retraction of the gallbladder infundibulum. Additionally, use of an end viewing scope, excessive use of cautery, physician inexperience, and aberrant biliary anatomy can play a role in these injuries.
Doctor. What about the role of intraoperative colangiography?
Intraoperative colangiography, IOC, can be used to define biliary anatomy. There is ongoing debate about whether routine IOC would help prevent bile duct injuries during LC. Some have maintained that routine IOC is technically challenging, adds cost and time to the procedure, and is unnecessary for the majority of patients. These surgeons selectively use preoperative endoscopic retrograde cholangiopancreatography, ERCP, and perform IOC based on abnormal liver function tests or a dilated common bile duct on preoperative ultrasound. A survey of general surgeons in the United States demonstrated that only 27% use IOC routinely. However, others feel strongly that IOC should be performed routinely as part of all LC so that the operative team is familiar with the procedure. A retrospective population-based study showed that intraoperative cholangiography has a significant protective effect for bile duct injury. The rate of injury was 2.1 per 1,000 when IOC was performed routinely during LC and 4.3 per 1,000 when IOC was not done. The difference was more striking when the cases were complex rather than routine. The rate of injury was 2.2 per 1,000 when IOC was performed and 16.9 per 1,000 when IOC was not done. Several smaller studies have addressed this question prospectively. In a prospective study of 303 patients undergoing LC, 148 had IOC performed routinely and 155 had selective IOC. There was no significant difference in the mean operating time, retained common bile duct (CBD), stones or CBD injury. A prospective study of 1241 patients undergoing LC showed that routine IOC was feasible in 92% of cases and anatomic variations that influenced operative management were found in 13% of cases. There were no complications from the IOC, but there were 4 bile duct injuries despite the use of IOC.
Doctor. What is the classification of biliary injuries?
The Strasberg and Bismuth classifications of biliary injury are based upon the degree and level of injury. The clinical presentation of the various injuries varies from asymptomatic bile leak that resolves spontaneously to complete obstruction of the extrahepatic biliary tree, which will present acutely within days. On the other hand, segmental biliary tree obstruction may not present for several years after the procedure. Type A. These are injuries that involve leakage into the gallbladder bed from either the minor hepatic ducts or the cystic duct, with no loss in continuity of the biliary tree. Type B and C. These are occlusion, type B, and transection, type C, injuries of aberrant right hepatic ducts. These are associated with cystic duct drainage into an aberrant right hepatic duct, an abnormality seen in as many as 2% of patients. In this setting, the right hepatic duct can be mistaken for the cystic duct at the point of insertion into either the main hepatic duct or common bile duct. When the injury to the duct is an occlusion type B, the patient may remain asymptomatic for years and then present with right upper quadrant pain and fever due to recurrent cholangitis, and segmental fibrosis and/or atrophy may result. In comparison, a biliary leak occurs when the duct is transected but not occluded type C. Concomitant injuries to the right hepatic artery are frequently associated with this particular problem. Type D. These are injuries with lateral damage to the common bile duct resulting in a biliary leak. They can usually be managed endoscopically but may progress to the more serious type E injury. Type E. Type E injuries involve the main ducts and are classified according to the level of injury in the biliary tree. Bismuth classification E1, bismuth type 1, transection greater than 2 cm from the confluence. E2, bismuth type 2, transection less than 2 cm from the confluence. E3, bismuth type 3, transection in the hilum. 4, bismuth type 4, separation of major ducts in the hilum. 5, bismuth type 5, type C injury plus injury in the hilum. Affected patients typically present with jaundice weeks to years after cholecystectomy. Surgical repair via hepatocholecystectomy is almost always required.
Doctor, what about recognition of bile duct injury?
In many cases, initial appropriate management of a bile duct injury recognized at the time of cholecystectomy can avoid the development of complications. About 1/3 of cases are recognized at the time of LC when sudden unexpected bile leakage is noted or a second cystic duct is encountered during the dissection. Intraoperative diagnosis. If bile leakage is observed during LC, repair should be performed only if the surgeon is skilled in these procedures. If not, then transfer to a colleague or another institution is warranted. Laparotomy should not be performed for diagnosis or drainage alone, as this may compound the injury. If a bile leak is recognized by an experienced surgical team, then early conversion to an open laparotomy and prompt colangiography should be performed. Colangiography will define the proximal anatomy to ensure that all hepatic ducts are accounted for and included in the reconstruction. A study of 88 patients with major bile duct injuries showed that when a cholangiogram was performed and cholangiographic data were complete, the initial repair was successful in 16 of 19 patients, 84%. In contrast, repairs of bile duct injuries were unsuccessful in 27 of 28 patients, 96%, when cholangiograms were not obtained before surgery. Additionally, the lack of complete cholangiographic information led to an inappropriate operation in some cases.
Doctor, when to postpone bile duct repair?
In some situations, a surgeon may encounter a bile duct injury that he or she may feel uncomfortable in attempting to repair at the time of the original operation. This may be due to a very proximal injury, very small bile ducts, associated inflammation, or the technical limitations of the surgeon. In this situation, externally draining the biliary system to avoid bile peritonitis and transfer to a tertiary care biliary surgeon without an attempt at repair is the best option. If possible, a catheter, such as a pediatric feeding tube or cholangiocatheter, should be placed into the proximal transected duct. This catheter can be secured loosely with a suture or clip, but care should be taken not to damage the duct and sacrifice length that may be needed for eventual reconstruction. The catheter is valuable both in controlling the bile leak and allowing access for cholangiography to facilitate placement of percutaneous transhepatic biliary catheters in the postoperative period. In addition, a closed section drain should be placed dependently in the gallbladder bed to further control the bile leak. The repair of a bile duct injury is a complicated procedure, and there is clear evidence that the best results are obtained at a center with experienced hepatobiliary surgeons and interventional radiologists. In one report, 64 biliary repairs performed by the primary surgeon or surgeons of comparable experiences were compared to 46 repairs performed by biliary surgeons at tertiary referral centers. A successful outcome was obtained in 94% of patients whose first repair was by a tertiary care biliary surgeon. In contrast, repair by the original laparoscopic surgeon was successful in only 17% of patients, and in no case was a second or third repair by the primary surgeon successful. The decision to transfer to a more experienced surgeon is considered good judgment and not abandonment. The patient and family should be carefully educated and advised about the reasoning for this decision.
Doctor, what about delayed presentation?
Injuries that are not recognized at the time of surgery present in a delayed fashion as either a bile leak or obstruction. Bile leakage into the peritoneal cavity will lead to severe abdominal pain, distension, nausea and emesis. If a bile leak is not controlled, this will result in a loculated collection, abscess formation, biliary ascites or bile peritonitis. Most patients with a major bile duct injury are not recognized at the original LC, but rather in the early postoperative period, either with symptoms of fever, abdominal pain, peritonitis or obstructive jaundice. The initial management of a patient who presents in a delayed fashion following a bile duct injury during LC depends on the nature of the injury and the mode and timing of the presentation.
Doctor, what about bile leak?
If a patient presents early following cholecystectomy, the most common mode of presentation will be a bile leak. If exploration and an attempt at repair are performed when there is bile peritonitis due to an uncontrolled bile leak, the dissection in the right upper quadrant will be very difficult, and identification of the decompressed retracted biliary system may be impossible, especially in the hands of the inexperienced biliary surgeon. Biliary reconstruction under these circumstances is technically difficult and, if accomplished at all, will frequently lead to long-term failure in the form of recurrent leak or biliary stricture. Every attempt should be made to define the biliary anatomy using percutaneous colangiography and to drain and control the bile leak with percutaneous biliary stents and percutaneous intraabdominal drains. Repair is then ideally performed 6 to 8 weeks after control of the leak and after intraabdominal sepsis is resolved and intraabdominal inflammation is less.
Doctor, what about biliary obstruction?
In patients who present with jaundice and/or cholangitis from biliary obstruction, defining the anatomy with percutaneous cholangiography and biliary drainage are important to control sepsis associated with cholangitis before planning elective repair.
Doctor, what about the goal of operative management?
The goal of operative management of a bile duct injury is the establishment of bile flow into the proximal gastrointestinal tract in a manner that prevents cholangitis, sludge, or stone formation, restricture or, at end stage, biliary cirrhosis. This goal is best accomplished with a tension-free anastomosis between healthy tissues. A number of surgical alternatives exist for the repair of bile duct injuries, including end-to-end repair, Roux-en-Y hepaticojejunostomy or cholecystectomy, and cholecystectomy. The choice of repair depends on a number of factors, including the extent and location of the injury, the experience of the surgeon, and the timing of the repair.
Doctor, what about the repair options?
A number of options are available for bile duct repair. The choice depends on the type and extent of injury, segmental or accessory duct injury. If a segmental or accessory duct less than 3 mm has been injured, and colangiography demonstrates segmental or subsegmental drainage by the injured ductal system, simple ligation of the injured duct and placement of a drain is adequate. However, if the injured duct is 4 mm or larger, it is likely to drain multiple hepatic segments or the entire left or right lobe and therefore requires operative repair. Cholecystectomy. A bile duct injury is sometimes recognized during the performance of an intraoperative cholangiogram. Recognition usually occurs after the placement of a single clip across the bile duct, with the introduction of a cholangiocatheter via a small cholecystectomy. In most situations, the clip should be removed and small cholecystectomy closed with a single 4-0 or 5-0 absorbable suture. A T-tube may be necessary if the cholecystectomy is large. In either case, a closed suction drain should be placed in the area to control any postoperative bile leak. The natural history of simple clip application across the bile duct is not defined, but it is unlikely that a late bile duct stricture would develop. If such a stricture does develop, the option of endoscopic management with balloon dilatation and stenting is available and is usually associated with an excellent outcome.
Doctor, What about transection of common bile duct?
The most common injury involves the complete transection of the common bile duct or the common hepatic duct. The aims of any repair should be to maintain ductal length and not sacrifice tissue, as well as to create a repair that will not result in postoperative bile leakage. To accomplish these goals, all repairs at the time of initial operation should include external drainage.
Doctor, what about the short injured segment or distal injury?
If an injured segment of bile duct is short, less than 1 centimeter, and the two ends can be opposed without tension, an end-to-end anastomosis can be performed with placement of a T-tube through a separate cholecystectomy either above or below the anastomosis. This approach is seldom used, as it is associated with a high risk of stricture formation. Because the injured edges will need debridement before anastomosis, there are few cases where there will be sufficient healthy duct tissue to allow end-to-end anastomosis, and accordingly the long-term success rate for this technique is poor. In the majority of cases, a hepatocollageonostomy represents the best choice for repair. Advantages of the end-to-end anastomosis are that it is less complex and allows endoscopic transampullary colangiography and stenting to treat any late stricture. If a Roux limb is created and a stricture develops, percutaneous access will ultimately be necessary in almost all cases. Some groups have reported acceptable outcomes with end-to-end anastomosis. One retrospective study reported less early postoperative complications in 45 patients treated with end-to-end anastomosis than 49 patients who underwent hepatocollageonostomies. Long-term results of both surgical approaches were comparable. There were no significant differences in stricture formation, general health status, or quality of life between the two groups. If this approach is chosen, generous mobilization of the duodenum out of the retroperitoneum, Kocher maneuver, can be used to help approximate the injured ends of the bile duct. A Kocher maneuver is the dissection of the lateral peritoneal attachments of the duodenum to allow inspection of the duodenum, pancreas, and other retroperitoneal structures. Regardless of the choice of reconstruction, the surgeon should always consider getting an experienced colleague to help with both the intraoperative decision-making and reconstruction, if available.
Doctor, what about long injured segment or proximal injury?
For proximal injuries, or if the injured segment of bile duct is greater than 1 centimeter in length, an end-to-end bile duct anastomosis should be avoided because of the excessive tension that usually exists in these situations. In these circumstances, the distal bile duct should be oversewn, and the proximal bile duct should be debrided of injured tissue and anastomosed in an end-to-side fashion to a Roux-en-Y jejunal limb. The use of a Roux-en-Y jejunal limb is preferable to an anastomosis to the duodenum because in the latter case an anastomotic leak can result in a duodenal fistula. A trans-anastomotic stent can be placed retrograde to the transected duct exiting the hepatic parenchyma to allow postoperative external drainage. In addition, a closed suction drain should be placed in the area of the anastomosis to control any postoperative bile leak. The details of reconstruction vary depending upon the particular anatomic features of the injury or stricture. Type E1, bismuth 1, for injuries with over 2 centimeters of healthy common hepatic duct preserved, a simple end-to-side biliary enteric anastomosis to a Roux limb will suffice. Type E2 and E3, bismuth 2 and 3, for injuries in which less than 2 centimeters of healthy hepatic duct is preserved, bismuth 2, or that involve the bifurcation of the hepatic ducts, but in which the right and left ducts communicate, bismuth 3, the hilar plate of the liver may need to be lowered and the dichotomy extended along a short length of the right or left hepatic duct to allow a common biliary enteric anastomosis. Type E4, bismuth 4, injuries that completely separate the right and left systems, bismuth 4, require separate right and left biliary enteric anastomoses. In rare cases, suitable duct length outside the hepatic parenchyma cannot be obtained, and these cases necessitate isolation of the intrahepatic biliary system. Intraoperative ultrasound may be necessary in these situations. The segment 2 duct can be located and isolated as it courses superficially in the inferior posterior surface of this segment to the liver. The parenchyma is excised over the duct, and the duct is opened along its length for 2 centimeters. A side-to-side biliary enteric anastomosis to a Roux limb is then created. Similarly, the segment 3 duct can be isolated on the medial anterior surface of segment 3, just lateral to the insertion of the falciform ligament. This duct is located deep in the liver parenchyma, and a wedge of liver parenchyma must be removed to complete the exposure of the duct. Type E5, bismuth 5. The most common procedure for biliary reconstruction following a type E5 injury is Roux-en-Y hepatocollageonostomy with transanastomotic stents.
Doctor, what about the operative technique?
If biliary stents are in place prior to surgery, these should be advanced by the interventional radiologist to cross the transected segment of duct into the subhepatic space. If the duct is completely clipped off, the catheters should be advanced right up to the transected end. This is important, as the catheters will help the surgeon identify the transected duct, which is usually retracted to the liver and surrounded by inflammation and adhesions. The bile duct proximal to the injury is carefully dissected circumferentially in a cephalad direction for a distance not to exceed 5 mm. This process is facilitated by having a biliary catheter extending through the end of the transected duct. The catheter can be identified early and followed back to the transected duct, which facilitates mobilization prior to reconstruction. Excessive proximal dissection of the transected duct should be avoided to prevent vascular compromise of the duct. A radiologic guide wire is then placed in the catheters. A series of Caudet catheters may then be passed over the guide wire to dilate the system, and then the appropriately sized, soft celastic stents are placed over the guide wires. The celastic stents are 12 to 22 French in size and have multiple side holes along 40% of their length. The side holes are left to reside within the intrahepatic biliary tree and the portion of the Roux-en-Y jejunal limb used for the biliary anastomosis. The end of the stent without the side holes exits through the liver parenchyma and is brought out through a stab wound in the upper abdominal wall. The biliary stents help decrease the possibility of stricture at the anastomosis. Celastic is soft and non-reactive, which minimizes the possibility of tissue damage and maximizes patient comfort. The multiple side holes help facilitate flushing and prevent obstruction of the biliary flow. After the stents have been placed, a Roux-en-Y limb is prepared and the anastomosis completed as an end-to-side hepatocollageonostomy. The anastomosis is usually done with interrupted 4-0 or 5-0 absorbable sutures. Closed suction drains are placed behind the anastomosis. Postoperatively, the celastic stents are left to gravity drainage for 3 to 4 days. A postoperative cholangiogram is then performed, and if that study is satisfactory, the stents are internalized. The length of time that the stents are left in place after surgery is variable and determined by the nature of the injury, the patient's clinical course, and follow-up cholangiography.
Doctor, what about morbidity and mortality?
The perioperative outcomes of surgical repair for biliary injuries following laparoscopic surgery have been reported in a series of 200 patients. The postoperative mortality was 1.7% and the incidence of postoperative complications was 43%. The most common complications were wound infections, 8%, cholangitis, 6%, and intraabdominal abscess, 3%. Early postoperative cholangiography revealed an anastomotic leak in 5% and extravasation of the liver dome stent site in 10% of patients. None of the patients required reoperation. Postoperative radiologic intervention, including percutaneous abscess drainage, was required in 9 patients, 5%, and new stent placement was required in 4 patients, 2%. Similar results have been reported in other series. A study of long-term outcomes in 142 patients following surgery for bile duct injuries showed that a successful outcome without the need for long-term biliary stents was ultimately achieved in 98% of patients. Patients who failed initial surgical management underwent either surgical revision, 1 case, or balloon dilatation. Only 3 patients continued to require long-term biliary stents to prevent symptoms, biliary obstruction, and/or cholangitis.
Doctor, what about quality of life?
Several studies have examined quality of life (QOL) of patients following surgical repair of bile duct injuries, and most demonstrate return of the individual to baseline functional health. One study compared QOL in patients who underwent successful surgical reconstruction of bile duct injury to age-matched individuals who had undergone recent uncomplicated LC and to age-matched healthy controls. The patients that had a successful bile duct reconstruction were not statistically different from the controls in the physical and social domains, but did score lower in the psychological domain of the assessment. The pursuit of a lawsuit related to the injury appeared to be a significant factor in influencing the quality of life in all domains.
Doctor, can you tell us the summary and your recommendations?
Common bile duct injuries represent a serious and challenging surgical complication. These complex injuries are most often a consequence of laparoscopic cholecystectomy. Proper management requires that the surgical team has appropriate skill and experience with complex hepatobiliary surgery. Injury to the common bile duct occurs most commonly when it is mistaken for the cystic duct. Intraoperative colangiography delineates biliary anatomy, and thus, may decrease the risk of iatrogenic common bile duct injury. Colangiography is performed routinely by some surgeons to reinforce familiarity with the procedure and should be performed with a low threshold in any patient for whom anatomic abnormalities are suspected. The Strasberg and Bismuth classifications of biliary injury are based upon the degree and level of injury. About 1/3 of bile duct injuries are recognized at the time of laparoscopic cholecystectomy. If bile leakage is observed after the completion of the cholecystectomy, the appropriately trained surgeon proceeds with conversion to an open procedure, intraoperative cholangiography, and repair. Immediate repair is best not attempted in patients with a very proximal bile duct injury, very small bile ducts, or associated inflammation. Drainage should be established to control the bile leak and prevent bile peritonitis. The patient should be transferred to an appropriate facility, if the treating surgeon has limited experience with complex hepatobiliary surgery. Most patients with a major bile duct injury are not recognized intraoperatively during laparoscopic cholecystectomy, but present in a delayed manner with postoperative fever, abdominal pain, peritonitis indicative of a bile leak, or obstructive jaundice. For patients who present with a postoperative bile leak, percutaneous cholangiography is performed to define the biliary anatomy, and the bile leak controlled using percutaneous biliary stents or intraabdominal drains. Repair is performed 6 to 8 weeks after control of the leak once intraabdominal sepsis is resolved. For patients who present with biliary obstruction, cholangiography and biliary drainage are indicated to control sepsis associated with cholangitis prior to repair. The goal of operative management of a bile duct injury is to re-establish flow of bile into the proximal gastrointestinal tract in a manner that prevents sludge, stone formation, stricture, cholangitis, and biliary cirrhosis. We suggest end-to-side over end-to-end anastomosis for hepatococcygeinostomy is the best option for the repair for most common bile duct injuries, grade 2C. The majority of patients undergoing surgery for bile duct injuries achieve a successful outcome without the need for long-term biliary stents.
Thanks, doctor, for this excellent interview and informations.
Thanks for you and your channel subscribers.
Please do not forget to like, share our videos, subscribe to YouTube channel No1doctor. Follow us in social media accounts in description below each video. With my best wishes.